For the cardiovascular system, monitor circulatory status such as skin color, peripheral pulses, and capillary refill, and for the absence of edema, numbness, and tingling. Monitor for bleeding. Assess the patient for rate and rhythm. A bounding, a bounding pulse may indicate hypertension, fluid overload, or client anxiety. Remember, a bounding pulse may indicate hypertension, fluid overload, or client anxiety. Monitor for signs of hypertension and hypotension. Monitor for cardiac dysrhythmias. Monitor for signs of thrombophlebitis, particularly in the veins who were in the lithotomy position during surgery. Encourage the use of anti-embolism stockings, if prescribed, to promote venous return, strengthen muscle tone, and prevent pooling of blood in the extremities. Assess the client for movement of the extremities. Review doctor's prescription regarding client positioning or restrictions. Encourage ambulation if prescribed before ambulation. Instruct the client to sit at the edge of the bed with his or her feet supported to assume balance. Unless contraindicated, place the patient in a low Fowler's position after surgery to increase the size of the thorax for lung expansion. Avoid positioning the post-operative client in a supine position until pharyngeal reflexes have returned. If the client is comatose or semi-comatose, position on the side. In addition, an oral airway may be needed. If the client is unable to get out of bed, turn the client every 1 to 2 hours. Assess level of consciousness. Make frequent periodic attempts to awaken the client until the client awakens. Orient the client to the environment. Speak in a soft tone. Filter out extraneous noises in the environment. Maintain the client's body temperature and prevent heat loss by providing the client with warm blankets and raising the room temperature as necessary. Monitor temperature. Monitor for signs of hypothermia that may have resulted from anesthesia, a cool operating room, or exposure of the skin and internal organs during surgery. Apply warm blankets and continue oxygen as prescribed only if the client experiences shivering. Assess surgical site, drains, and wound dressings. Remember, serous drainage. Serous drainage is a clear, watery like drainage may occur from an incision, but if excessive bleeding occurs from the site, notify the doctor. Assess the skin for redness, abrasions, or breakdown that may have resulted from surgical positioning. Monitor body temperature and wound for signs of infection. Maintain a dry, intact dressing. Change dressing as prescribed, noting the amount of bleeding or drainage, odor, and intactness of suture or staples. Wound drains should be patent. Prepare to assist with the removal of drains, as prescribed by the doctor when the draining amount becomes insignificant. Montgomery straps may be used when frequent dressing changes are anticipated to help to prevent skin irritation from frequent tape removal. An abdominal binder may be prescribed for obese and debilitated individuals to prevent dehiscence of the incision. Monitor IV fluid administration as prescribed. Record intake and output. Monitor for signs of fluid or electrolyte imbalances. Monitor intake and output and for nausea and vomiting. Maintain patency of the nasogastric tube if there is one. Monitor for abdominal distension. Monitor for passage of flatus and return of bowel sounds. Administer frequent oral care at least every 2 hours. Maintain the NPO status until the gag reflex and peristalsis return. Remember, maintain the NPO status until the gag reflex and peristalsis return. When oral fluids are permitted, start with ice, chips, and water. Ensure that the client advances to clear liquid and then to regular diet as prescribed and as client as can tolerate. To prevent aspiration, turn the client to a side-lying position if vomiting occurs. Have suctioning equipment available and ready to use. Assess the bladder for distension. Monitor urine output. Urinary output should be at least 30 ml per hour. Remember, after surgery, monitor urine output. Urinary output should be at least 30 ml per hour. If the client does not have a Foley catheter, the client is expected to void within 6 to 8 hours post-operatively, depending on the type of anesthesia administered. Ensure that the amount is at least 200 ml. Assess the type of anesthetic used and preoperative medication that the client received, and note whether the client received any pain medication in the post-anesthesia period. Assess for pain and inquire that the type and location of pain. Ask the client to rate the degree of pain on scale 1 to 10, with 10 being the most severe. If the client is unable to rate the pain with a numeric pain scale, then use a descriptor scale that lists words that describe different level of pain intensity, such as no pain, mild pain, moderate pain, and severe pain. Monitor for objective data related to pain, such as facial expression, body gestures, increased pulse rate, increased blood pressure, and increased respirations. Administer pain medication if prescribed. Ensure that the client with a PCA pump understands how to use it. If an opioid has been prescribed after administration, assess the client every 30 minutes for respiratory rate and pain relief. If non-invasive measures to use non-invasive measures to relieve post-operative pain, including provisions of distraction, comfort measures, positioning, back rubs, and a quiet and restful environment. Document effectiveness of the pain medication and non-invasive pain relief measures. Consider cultural practices and belief when planning pain management. Pneumonia. Pneumonia, an inflammation of the alveoli caused by an infectious process that may develop 3 to 5 days post-operatively as a result of infection, aspiration, or immobility. Post-operative assessment. Assess for factors that may increase the risk of pneumonia and atelectasis. Atelectasis. Atelectasis is a collapse or airless state of the lungs that may be the result of airway obstruction caused by accumulated secretions or failure of the client to breathe deep or ambulate about after surgery. A post-operative complication that usually occurs 1 to 2 days after surgery. Atelectasis occurs usually 1 to 2 days after surgery. For pneumonia and atelectasis, assess for factors that may increase the risk of pneumonia and atelectasis. Assess for dyspnea and increased respiratory rate. Assess for crackles over involved lung area. Assess for elevated temperature. Assess for productive cough and chest pain. Interventions. Assess lung and breath sounds. Reposition the client every 1 to 2 hours. Encourage the client to deep breathe, cough, and use the incentive spirometer as prescribed. Provide chest physiotherapy and postural drainage as prescribed. Encourage fluid intake and early ambulation. Use suction to clear secretion if the client is unable to cough. Post-operative complications are pneumonia and atelectasis, hypoxemia, pulmonary embolism, hemorrhage, shock, thrombophlebitis, urinary retention, constipation, paralytic ileus, wound infection, wound dehiscence, wound evisceration. Hypoxia is an inadequate concentration of oxygen in arterial blood in the post-operative client. Hypoxia can be due to shallow breathing from the effects of anesthesia or medication. Assessment of hypoxia are restlessness, dyspnea, diaphoresis, tachycardia, hypertension, cyanosis. Intervention for hypoxemia. Monitor for signs of hypoxemia. Notify the doctor. Monitor lung sounds and pulse oximetry. Administer oxygen if prescribed. Encourage deep breathing and coughing and use of the incentive spirometer. Turn and reposition the client frequently. Encourage ambulation every 1 to 2 hours. Pulmonary embolism. An embolus blocking the pulmonary artery and disrupting blood flow to one or more lobes of the lung. Assessment for pulmonary embolism. Sudden dyspnea, sudden sharp chest or upper abdominal pain. Cyanosis, tachycardia, a drop in blood pressure. Intervention for pulmonary embolism. Notify the doctor immediately because pulmonary embolism may be life-threatening and requires emergency action. Monitor vital signs. Administer oxygen and medication as prescribed. Hemorrhage. Hemorrhage is the loss of large amount of blood externally or internally in a short time period. Assessment for hemorrhage. Restlessness, weak and rapid pulse, hypotension, tachypnea, cool, clammy skin, reduce urine output. Interventions for hemorrhage. Provide pressure to the site of bleeding. Notify the doctor. Administer oxygen as prescribed. Administer IV fluids and blood as prescribed. Prepare the client for surgical procedure if necessary. Shock. Shock is a loss of circulatory fluid volume, which usually is caused by hemorrhage. Assessment is similar to the assessment finding in hemorrhage. Intervention for shock. If shock develops, elevate the feet. Remember, if shock develops, elevate the feet. Notify the doctor. Determine and treat the cause of shock. Administer oxygen if prescribed. Monitor level of consciousness. Monitor vital signs for increased pulse or decreased blood pressure. Monitor intake and output. Assess color, temperature, turgor, and moisture of the skin and mucous membrane. Administer IV fluids, blood, and colloid solutions as prescribed. If the client has spinal anesthesia, remember, if the client has spinal anesthesia, do not elevate the leg any higher than placing them on the pillow. Otherwise, the diaphragm muscles needed for effective breathing could be impaired. The diaphragm muscles needed for effective breathing could be impaired. Thrombophlebitis. Thrombophlebitis is an inflammation of a vein, often accompanied by clot formation. Veins in the legs are affected most commonly. Assessment for thrombophlebitis. Vein inflammation, aching or cramping pain. Vein feels hard and cord-like and is tender to touch. Elevated temperature. Interventions for thrombophlebitis. Monitor legs for swelling, inflammation, pain, tenderness, venous distension, and cyanosis. Notify the doctor if any of these signs are present. Elevate the extremity 30 degrees without allowing any pressure of the popliteal area. Without any pressure on the popliteal area. Encourage the use of Tie embolism stockings as prescribed. Remove stockings twice a